Well, good morning, all. Good morning, and welcome to Medical Grand Rounds. I'm Dr. Laura Lacher. We'll begin with just a few reminders and logistics before getting into today's introductions. So next week, we will be hearing from Dr. Kamal Shoyman of the Mayo Clinic, who will be presenting on autonomic dysfunction. And again, I am here in Southern Auditorium at Providence St. Vincent Medical Center. Welcome to those of you joining us online on the Teams Live platform. We will often be here in person at St. Vincent and occasionally also in person at Providence Portland on Wednesdays. Please stay tuned to your email each week to understand when we will be in person and when it will be only virtual. Next week, our speaker will only be joining virtually. And you can earn CME credit by being with us here live in person, by watching live virtual, or by watching a recording of the event. And that recording is available at the same link as the invite for Grand Rounds. I'll be monitoring the Q&A throughout this session, so please go ahead and file those thoughts away or post them online. And now on to introductions. I am delighted today to introduce one of my favorite Grand Rounds of the year. We are joined today by the outstanding internal medicine residents from our program here at Providence St. Vincent. And they will be presenting work that they have been preparing for the Oregon American College of Physicians Conference, which will be happening later this week in Salem, Oregon. Some have prepared case reports that represent some of the most challenging and interesting cases throughout Providence St. Vincent Hospital this year, put together with important teaching points for clinicians. Other residents will be sharing their quality improvement projects. This is work that they have done within our clinic and within our hospital to further the outstanding care of our patients. So please join me in welcoming today's speakers, several of our St. Vincent Internal Medicine residents, and I will ask them to introduce themselves individually as they present their poster.
Well, good morning. Hello, my name is Kemin Fina. I'm a second-year resident here at Providence St. Vincent, and I'll be presenting a case of urine luck, a case of acute renal failure and recovery. Working up the etiology of acute renal failure is an important skill for the training internist. Bile cast nephropathy is an often overlooked cause of acute kidney injury in patients with concomitant liver disease. Renal biopsy is considered the gold standard test for the diagnosis of bile cast nephropathy. However, this case will highlight the necessity to consider individual factors to provide the best possible patient-centered care. This is a case of a 71-year-old female who has a history of CKD3, diabetes, prior B-cell lymphoma, which led to the temporary obstructive nephropathy and left this patient with one functional kidney. She presented initially to her primary physician for progressively worsening fatigue and dark urine for 1 week. Labs found an acute renal failure with creatinine greater than 6 on a baseline of 1.2, and the patient was referred to the emergency department. Urinalysis was notable for 3+ blood, 1+ bilirubin, protein, amorphous crystals, and calcium oxalate crystals. She underwent a very extensive workup, including glomerulonephritis testing, which was all unrevealing. Furthermore, labs indicated biliary obstruction with a total bilirubin of greater than 9, ALK phosphatase greater than 1,000, and mildly elevated AST and ALT levels. A CT abdomen non-contrast also found pancreatic head enlargement, which was ultimately diagnosed by biopsy as adenocarcinoma. A biliary stent was placed to relieve the obstruction, and intermittent hemodialysis led to improvement in her bilirubin levels, and urine output increased. Again, here I'd like to highlight in figure 2 that due to her left renal atrophy, prior obstruction, and her remote history of lymphoma, a diagnostic biopsy was not performed due to her right kidney being her sole functioning kidney. After 3 months, her renal function recovered and she was able to discontinue dialysis. She's currently undergoing neoadjuvant chemotherapy for pancreatic cancer, stage 1, and a prior planned surgical resection. This case of acute renal failure due to a suspected bile cast nephropathy is a great reminder of an often overlooked etiology of kidney injury. Renal biopsy is considered the gold standard for definitive diagnosis of bile cast nephropathy, as you can see in figure 1, the pathology that you might see with HD and Hall staining. However, exclusion of other causes and the temporal correlation between the level of her serum bilirubin levels and her improved renal function over time supports our diagnosis of bile acid nephropathy here. Improving urine output compared to the serum bilirubin level can be seen in figure 2 over the time course of her hospitalization. And I think this marker was accidentally shifted, but I'll adjust that in my final poster. The horizontal line should actually be at about day 3, where her biliary stent was placed on 6/4. The mechanism of renal injury by bile acid nephropathy is not fully understood, but bile acids are thought to cause tubular obstruction and interstitial inflammation. Underdiagnosis of bile acid nephropathy is likely related to a poorly understood mechanism of action and lack of a simple diagnostic test. As seen in this case, the treatment of bile acid nephropathy will prioritize addressing the underlying pathology that led to hyperbilirubinemia, and furthermore, this often overlooked problem is potentially a reversible cause of acute renal failure. This case serves as a reminder that individualized patient-centered care and avoiding renal biopsy in someone who has a solitary functional kidney can save patients from invasive treatments, unnecessary risks, and like in this case, lead to a very lucky ending.
Thank you much, Dr. Afina. We have several speakers to get through today. I can briefly accept a question in the room if there's any burning questions out there. Great, thank you. I think with that, we will move on to our next presenter.
All right, hello everybody. My name is Abby Linseth, and I am a second-year internal medicine resident at Providence St. Vincent. So hypercalcemia of malignancy occurs in about 20% of cancer patients, especially in advanced disease, and is not often seen as the initial presentation of malignancy. The most common cause is multiple myeloma, and the most common mechanism is via the production of parathyroid hormone-related peptide, or PTHrP. So this is a case of severe hypercalcemia as the initial presentation of an elusive and aggressive T-cell non-Hodgkin's lymphoma. So a 67-year-old female presented with primary sclerosing cholangitis, presented to her primary care provider for a month of drenching night sweats, fatigue, and unintentional weight loss. Her symptoms persisted, and repeat labs showed rapidly progressive hypercalcemia and a new anemia as seen in Table 1. At the insistence of her primary care provider, she was presented to the ED for further workup and management. Upon her admission to the hospital, she had progressive leukopenia and anemia with severe hypercalcemia, for which she was treated with aggressive IV hydration and zoledronic acid. On hospital day 2, her parathyroid hormone resulted as suppressed and her vitamin D level was normal. Given its perceived lack of impact on acute management of her severe hypercalcemia, a parathyroid hormone-related peptide was deferred. With her presentation and age, suspicion for multiple myeloma was high. Serum and urine protein electrophoresis, in addition to flow cytometry, were normal, and there was no adenopathy, masses, or lytic lesions on her whole body CT. These negative results lowered the suspicion for multiple myeloma and a solid malignancy, but hematologic causes remained likely. As such, a bone marrow biopsy was performed, which showed nonspecific T-cell infiltration and marked fibrotic changes, and additional genetic studies were sent off. Ultimately, her pancytopenia plateaued, and she was determined to be stable for discharge with close oncology follow-up. Her final diagnosis was established nearly 2 weeks after bone marrow biopsy as an aggressive form of T-cell non-Hodgkin's lymphoma. She follows with oncology and is currently receiving treatment with R-CHOP. So the release of parathyroid hormone-related peptide is the most common cause of hypercalcemia of malignancy, as indicated in Figure 1. This contrasts with multiple myeloma, the initial top differential in this case, which causes hypercalcemia of malignancy versus its pathognomonic lytic lesions. In most inpatient settings, PTHrP is costly, slow to result, and thought to seldom impact inpatient management of acute hypercalcemia. For these reasons, it is not uncommon for practitioners to forgo it in the acute setting, as occurred in this case. Contrary to this, I argue that because malignancy generally favors one mechanism when causing hypercalcemia, PTHrP can help focus the differential and potentially provide meaningful clarity. I wonder, had PTHRP been initially drawn in this case, could it have guided the pathologist's initial evaluation towards the most likely etiology, say lymphoma versus leukemia versus multiple myeloma, and perhaps yielded a timelier diagnosis? The outcome of this case is yet to be determined, but I do wonder if her delay in diagnosis negatively impacted her outcome. Furthermore, hypercalcemia of malignancy is considered a poor prognostic factor. Nearly 50% of patients die within 30 days of detection. These patients do not have time to spare, especially when hypercalcemia is the initial presentation of malignancy. As such, the next time I see a case of undifferentiated hypercalcemia, where there is a high suspicion for malignancy, I will order a PTHRP as it just may be worth the cost.
Great. Thank you, Dr. Linseth. We have a question.
Do you know, once they were able to make the diagnosis on the bone marrow, was there any imaging, like a PET, that found it in other places that might have been detected early?
Yeah, we actually did a PET scan inpatient while she was waiting for the bone marrow biopsy because it was taking so long, and it was unremarkable. No lymphadenopathy, nothing on the bone marrow that could have helped. No, that's okay.
Oh my, what a diagnostic mystery. Thank you, Dr. Linseth. We will welcome our next speaker.
Hello, everyone. I'm Christina Patel, and I'm a second-year medicine resident, and I'm going to talk about my poster called Going Down the Long Rabbit Hole. So imagine this. You woke in a busy clinic. You have 30 minutes to see this patient who's coming in for follow-up management of his most recent gout flare. After changing his regimen, discussing the changes with him, talking with your preceptor, making a plan off the AVS, he mentions on the way out that, by the way, he's noticed these large bloody stools for the past couple weeks. Since you've just been talking about his gout flare, and you know he's been on this prolonged prednisone taper, taking these daily NSAIDs, and drinking a lot of alcohol, you quickly assume that this is likely peptic ulcer disease or a PUD. Order the typical woke-up treatment, including CBC, PPI. Also ask him to get that endoscopic evaluation with GI, since he does have a long since treated history of renal cell carcinoma. His hemoglobin was toned low at 10.3, so you decide to see him sooner. He's now reporting resolution of the bloody stools, which is great, so you think his PUD is likely healing over now. But just to make sure, you go ahead with another CBC check and see that his hemoglobin is now 9.1. Since he did tell you the bloody stools were gone and the diagnosis of PUD has already been made, you tell him to continue with the peptic ulcer treatment and still to come see his GI sooner. Unfortunately, he doesn't make it in time to see the GI doctor. He comes to the clinic feeling extremely short of breath. He's set in 80s on WIM-L and appears very pale. So you send him to the ED. Doing handoff to the ED physician, you focus the concern on potential PUD. So the ED doc sets out to woke up and treat a presumed PUD. He gets the EGD, as you can see in Figure 1, and it comes back completely normal. So they go ahead with the CT of his abdomen, and it reveals, as you can see in Figure 2 at the arrow, that he has something in his right kidney fossa. He had his right kidney removed several years ago when he got his renal cell carcinoma treated, but it looks like it's returned. It seems the mass is now invading his intestines, which likely caused the bleeding and the bloody stools. So this was not a peptic ulcer. So what happened? How could this have been found sooner? A crucial technique that we are often taught in medical school is to set the agenda. Agenda setting has several benefits, including 1, maximizing efficiency, 2, differentiating which type of clinical reasoning to utilize, and 3, reducing the potential for cognitive biases. Despite the benefits, studies have shown that PCPs utilize this tool only 49% of the time and allow patients a mere 11 seconds to set the agenda before we interrupt them with our agenda. Also, potentially embarrassing symptoms like bloody stools contribute to a large number of hand on the doorknob or by the way questions. During this initial encounter, an agenda was not established. The focus was gout management, and the patient's concern for bloody stools was the hand on the doorknob question. Given the high prevalence of PUD and its multiple risk factors, he was diagnosed with PUD. This is an example of availability bias using type 1 thinking. His second visit relied on the previous diagnosis, so additional clinical reasoning was suspended, despite the patient saying the bloody stools have resolved, while his anemia continued to worsen. This is an example of vanquine bias, rejecting type 2 thinking. When he returned in a decompensated state, handoff to the next physician influenced the woke up a PUD with an EGD and no advanced imaging. This is an example of the Feynman effect. So there are a few opportunities during his clinical course that we can learn from. Forced agenda setting is a commonly taught, though poorly utilized skill that saves clinicians time while reducing the chances for those hand on the doorknob or by the way questions. Second, these last-minute questions were most susceptible to type 1 thinking, which leads to potential flaws in our thinking and cognitive biases. Thirdly, one bias can snowball into more biases. And finally, we should always stop and challenge ourselves whenever a clinical course is not following the expected clinical path. Doing so will help us escape the rabbit hole and improve patient care. Thank you.
Fabulous. Many thanks, Dr. Patel. Any questions? Great. Thank you for your clarity. We'll invite our next speaker.
Hi, everybody. My name is Amanda Tepp, and I'm a second-year resident. And today I'll be presenting a case of Cushing's syndrome. So Cushing's syndrome is caused by chronic exposure to excess glucocorticoids. And one cause of endogenous Cushing's syndrome is ectopic ACTH syndrome. This syndrome is difficult to diagnose as the tumors are often small and easily missed on imaging. In addition, lung neuroendocrine tumors are the most common cause of this syndrome. Today, I'm presenting a patient with Cushing's syndrome who was found to have an ectopic source of ACTH production. Our patient is a 32-year-old male who presented with a 6-month history of facial rounding. Throughout this time period, he also noticed a dorsal cervical fat pad, proximal muscle weakness, easy bruising, and high blood pressure. His ACTH level was high, and his urine-free cortisol and salivary cortisol tests were all elevated. An MRI was done, which did not show a pituitary adenoma. ACTH secreting pituitary adenomas are often easily missed on imaging because they're so small. However, given this patient's rapid clinical progression, we next decided to look for an ectopic source. As you can see in figure 1, a CT was done, which showed a pulmonary nodule measuring 1.2 centimeters in the right middle lobe of the lung. The right middle lobe was then resected, and pathology confirmed a pulmonary carcinoid tumor. His post-operative course was complicated by hemorrhage requiring chest tube placement, as well as a pneumothorax after chest tube removal. Post-operatively, his cortisol levels slowly decreased and eventually normalized, and at his 1-month post-op visit, his Cushing's features were all improving, but not yet resolved. So our patient was found to have ectopic ACTH production from a pulmonary carcinoid tumor. Pulmonary carcinoid tumors are rare neuroendocrine tumors with an annual incidence of 2.3 to 2.8 cases per million people. Cushing's syndrome is characterized as either ACTH dependent or ACTH independent. In ACTH dependent Cushing's, the source of ACTH is often either from a pituitary adenoma or an ectopic ACTH secreting tumor. If a patient is found to have confirmed ACTH-dependent disease, then the first step is for them to undergo a pituitary MRI. If that MRI shows a pituitary adenoma, then they have Cushing's disease. If the MRI is negative, then the next step is for them to undergo further workup with a CT or MRI of the chest and abdomen to look for an ectopic source. As seen in the flowchart in figure 2, if a patient has an ectopic ACTH-secreting tumor, then they have excess ACTH, which then stimulates the adrenal glands to produce excess cortisol, leading to Cushing's. Patients with ectopic ACTH production often have rapidly progressing Cushing's features, which is often a clue to the diagnosis of this condition. If they are found to have an ectopic ACTH secreting tumor, they sometimes undergo a functional study, such as an octreotide or PET dotatate scan, to confirm if they indeed have a neuroendocrine tumor and to prevent unnecessary removal of an incidental tumor. In summary, if patients are found to have ACTH-dependent Cushing syndrome without evidence of a pituitary adenoma, then they need further workup with more imaging to look for an ectopic source. Although resection of these tumors is associated with lots of risk, resection is necessary to establish a diagnosis and to provide definitive management for these patients.
Thank you, Dr. Tepp. Any questions in the room? Great, thank you. We'll welcome our next speaker.
All right, my name is Michael Knapp. I'm a second-year IM resident, and today I'll be talking about anchoring bias leaves insulinoma workup lost at sea. Anchoring bias refers to the tendency to stick with initial impressions even as new information becomes available. The importance of adjusting an initial diagnostic hypothesis is highlighted in this case of methadone-induced hypoglycemia. A 73-year-old male with a history of CKD and a 50-year history of methadone use presented to the ED with persistently worsening diaphoresis, syncope, and confusion in the setting of recurrent episodes of hypoglycemia. These episodes first occurred 2 months prior to arrival, shortly after his methadone regimen was increased from 140 milligrams to 180 per day. As shown in the laboratory figure on the left, this patient's early workup met criteria for an insulinoma, with a blood glucose level of 43 in the setting of elevated proinsulin, C-peptide, total insulin, and beta-hydroxybutyrase, with no evidence of sulfonylurea use, thus prompting our search for an insulinoma. And subsequently, our team underwent an exhaustive imaging workup that started with a CT abdomen pelvis without any evidence of a pancreatic mass. We then pursued a more sensitive endoscopic pancreatic ultrasound, which re-demonstrated normal findings. And lastly, despite any prior imaging evidence, our team remained persistent and ordered a gold standard PET-CT dodadate scan, which again was negative. After having definitively ruled out an insulinoma, our team explored alternative etiologies of persistent hypoglycemia outside of our original hypothesis. Eventually, a literature review revealed that high doses of methadone in patients with CKD can induce hyperinsulinemia and result in hyperglycemia. Throughout our imaging workup, the patient remained hospitalized and persistently hypoglycemic, requiring IV glucose supplementation, depicted in the graph shown here. From top down, in orange, we have a visual representation of our methadone taper throughout the patient's hospital course. The horizontal arrows in blue and red represent the hospital days that required IV glucose supplementation in an attempt to maintain glucose naders, shown in blue, from dipping below the lower threshold of euglycemia, shown in yellow. Most importantly, the turquoise star marks the first day of the methadone taper where the patient was able to maintain euglycemia without any IV glucose support. This occurred on hospital day 24 at a methadone dosage of 110, down from 180 on arrival. Methadone can induce hypoglycemia. The average per day rate of methadone-associated hypoglycemia for those taking more than 80 milligrams is 8%. The mechanism of action of methadone-induced hypoglycemia is unclear, although proposed mechanisms include the promotion of pancreatic insulin release versus the suppression of counter-regulatory mechanisms of glucagon and epinephrine. The anchoring effect often manifests when an initial piece of information is relied upon too heavily. And this case highlights how dependence on our initial labs led to an expensive and unremarkable imaging workup that delayed a unifying and albeit more enigmatic diagnosis. This case teaches us that efforts should be made to resist the diagnostic momentum based on an initial hypothesis, especially before pursuing other potentially elusive causes.
Thanks for teaching us about this important problem. What happened with his opioid use disorder symptoms as you tapered his methadone from 180 to 110?
As like through his hospital course? Yeah, so chemical dependency was involved, and we actually, as you can see, proceeded with a very slow taper. And he did not experience any significant withdrawal. I think the majority of our management had to do with really just mental support. Yeah. Mm-hmm.
Great. Many thanks, Dr. Knapp. Outstanding. We'll invite our next speaker.
Good morning. My name is Beth Koschel, and I'm excited to share with you guys my quality improvement project on sepsis patient education. So as we know, sepsis is a highly prevalent disease affecting millions of patients worldwide annually, and it remains the leading cause of death within hospitalized patients in this country despite improvements in treatment. Nationwide surveys of sepsis patients consistently show dissatisfaction with sepsis-related care, including a lack of education regarding the diagnosis. Within these surveys, patients with lower socioeconomic status and racial and ethnic minorities consistently show lower self-reported outcomes as well. In response to this growing body of data, the Surviving Sepsis Campaign 2021 guidelines included a new recommendation to include education regarding sepsis at diagnosis, treatment, and recovery expectations in both written and verbal format. Providence St. Vincent, while we have systematic sepsis care pathways, we didn't previously have standardized means of providing this education to patients. This project aimed to address that knowledge gap and hopefully improve patient-reported outcomes. So the beginning of this project involved creation of said educational intervention, which ultimately became what you see in Figure 1, a brochure that defines sepsis, outlines treatment and prognosis, and establishes a general length of stay and expectations for recovery. It's presented in an easy-to-read format available in 6 different languages to specifically target our patients with lower socioeconomic status and our racial and ethnic minorities. We then focus on incorporating this into the electronic health record. Within Providence, we use the sepsis order set to capture and improve patient care for all patients with sepsis. And we're able to link this brochure with that sepsis order set. So anyone admitted with the order set has this brochure available in the electronic health record and can be printed directly from their chart. We then pivoted to caregiver education to promote engagement in the sepsis work and introduce this new educational tool. As you can see in image 1 up on the right, our main intervention here involved deploying a roving cart with prize wheel and prizes throughout Sepsis Awareness Month and reached over 500 caregivers here at Providence St. Vincent. Then shifting to our results of this project up in Figure 2, it looks at the timeline from May of 2022 to May of this year. The red line shows the total number of patients admitted to Providence St. Vincent with sepsis throughout the year. The yellow line shows the number of patients who had the sepsis order set used and were essentially eligible to be given the brochure. And the green line shows the number of patients who actually received the brochure. The red arrow indicates when the brochure went live in our electronic health record in July of 2022, and the Sepsis Awareness Month is highlighted by the blue arrow in September of 2022. After both interventions, you can see the green line going up. By the end of our our study period in May of this year, 78% of patients who had the sepsis order set used were receiving this brochure, which ended up being a total of 805 patients over the course of this past year. I really want to focus on Figure 3 here, the project spread. While 800 plus patients here at St. Vincent were exposed to this education, the magnitude of spread is much larger. The brochure was able to be incorporated system-wide within Providence across 7 states and a total of 51 hospitals. And so Providence serves over 40,000 sepsis patients per year, and the potential for this educational brochure to impact patient care really expands outside of this hospital. And so we're excited about continuing next steps of this project, including ongoing workflow of inpatient and post-discharge care teams to increase the number of patients exposed to the brochure, hopefully getting them more engaged in their care and improving patient-reported outcomes.
Just a quick comment. This is a phenomenal piece of work, Beth. Really wonderful. I mean, lives will be saved because of this, so you should feel really good about this. So great job. I just can't say enough good things about this kind of project. Just excites me. I think it's great. Thanks.
Kudos to that. Thank you, Dr. Kushel. All right, we'll invite our next speaker.
Okay. Hi, my name is Adriana Morris, and I'm pleased to present my quality improvement project completed throughout my residency at Providence St. Vincent. COPD is a prevalent disease in the United States and is the 3rd leading cause of hospital readmissions. Newly available triple inhalers combine a long-acting beta agonist, or LABA, inhaled corticosteroid, or ICS, and long-acting muscarinic antagonist, or LAMA, in a single device. Triple therapy inhalers are associated with reduced risk of hospitalization compared with LABA-LAMA therapy in some studies. This quality improvement project aimed to increase triple therapy inhaler prescribing at the time of discharge by 50% and reduce COPD 30-day readmission rates by 20% from the current rate of 13% to 10.4%. This uncontrolled before-after pilot project enrolled COPD inpatients at Providence St. Vincent between November 2020 to October 2022 as the pre-intervention period, and November 2022 to August 2023 as the post-intervention period. For the intervention, a partnership with pharmacy was established to evaluate insurance coverage of inhaled medications prior to discharge. Pharmacists identified eligible patients via daily workbench report with the following inclusion criteria: adults admitted for COPD exacerbation by a resident team and prescribed the hospital formulary for LABA ICS and LAMA inhalers as an inpatient. Pharmacists estimated copay at discharge for the prior to admission medications compared to a single triple inhaler, either Trelegy Ellipta, pictured in figure 4, or Breztri Aerosphere in figure 6. And they subsequently placed a progress note in the inpatient chart as seen in figure 5. Physicians were reminded to prescribe single triple inhaler therapy by use of discharge instructions smart phrase specific for COPD exacerbation seen in figure 1. During the intervention, 143 patients hospital-wide were eligible for triple therapy inhaler, of whom 19 received the smart phrase and 12 were prescribed the medication at discharge. Compared to the pre-intervention period, smart phrase use increased from 0.4% to 13.3%, as did triple therapy inhaler prescribing from 5.1% to 8.4%, noted in figure 2. The COPD 30-day readmission rate increased from 13% to 14.7%, seen in figure 3. Data used in this analysis is collected from all patients admitted to Providence St. Vincent with a COPD exacerbation, while the intervention was only done for patients admitted to a resident team, which is a much smaller percentage of patients. This quality improvement project removed 3 barriers to guideline concordant care for our COPD patients. First, we partnered with pharmacy to address potential cost barriers. Second, we used smart phrase to remind physicians that all patients admitted for COPD exacerbation should receive triple inhaler therapy. Most importantly, we improved patient experience by simplifying the inhaler regimen and for many patients, reducing the number of inhaler doses to just 1 puff per day. While readmission rate has not yet improved, we are optimistic that simplifying both the messaging and the treatment regimen is better for both patients and hospital systems. Our next step will be to spread beyond the resident service and to include hospitalist patients in our collaborative pharmacy workflow.
Outstanding work, Dr. Morse. I think we will invite up our last presenter for the poster part of today's session.
Good morning. I'm excited to tell you about my high value care project. To start, Advanced Care Planning, ACP, is a process that supports adults in understanding and sharing their personal values, life goals, and preferences regarding future medical care. Older, sicker patients particularly stand to benefit from ACP, and in 2018, 18% of the US population and 20% of the Oregon population were Medicare beneficiaries. The Medicare Annual Wellness Visit, or AWV, is a discrete opportunity to address ACP. ACP promotes patient-centered care, upholds patient autonomy, and may reduce healthcare costs. Prior to this project, 18.3% of primary care patients over 65 at PMG St. Vincent had a Goals of Care, or GOC, note documented. Recent addition of a GOC dot phrase to the AWV note template had resulted in GOC note completion at 38% of AWVs. This project aimed to increase the percentage of older adults with a GOC note by September 30th of 2023. My effort overall is part of a broader project to further ACP and capture goals of care discussions in a reliable place within the EPIC EMR, specifically the Advanced Care Planning tab in the green tile, as you can see at the bottom center of the screen. A literature review identified that priming patients for ACP discussions increased ACP completion during visits. Our stakeholder interviews with patients and staff showed that a priming letter that empowered patients to discuss ACP with their doctor was acceptable and feasible. We implemented distribution of a large font letter to all patients at AWV check-in and measured the percent of patients over 65 with any GOC note. We tracked percentage of AWVs with ACP documented by use of the standardized GOC dot phrase, which automatically pulls into the green tile. And then we also stratified by English language proficiency to look for possible disparities. At conclusion of the project, 43% of patients over 65 at PMG St. Vincent had achieved a GOC note. Throughout the intervention period, the rate of GOC documentation during AWVs was maintained at 40%, as you can see in the second graph on the screen. Among those with limited English proficiency, 4 of 5 quarters post-intervention did have a lower rate of GOC documentation for those patients compared to English language patients. Qualitatively, medical assistants did find the letters easy to distribute. This project maintained the rate of GOC discussions during AWVs while steadily increasing the percentage of older patients with a formally documented GOC note. Disparities in ACP documentation among limited English proficiency patients may be improved by translating the priming letter. As the percentage of patients over 65 with documented ACP increases, the percentage of individual AWVs with ACP may plateau, as stable preferences may not require a yearly reassessment. This low-cost, high-value intervention could be adopted in other primary care settings to enhance care plans and cost savings while empowering patients to be active participants in their care. Thank you very much for listening.
Many thanks, Dr. Shu, for your excellent work. Well, wonderful. I am excited to move on to the final segment of today's presentation. We have heard from several residents who prepared posters for the conference later this week. There is also a annual tradition of outstanding oral presentations, typically by a resident from each of our local residency programs. And so I'm delighted to introduce Dr. Omar Pandher, who will be giving today's oral presentation.
Great. Good morning, everybody. Thank you for your grace and patience in experiencing my talk today. I'm going to hop right into my case. So I have a 41-year-old woman with no past medical history. I know that's an ominous prognostic sign when we see that a lot of the times, but she presents primarily with the complaints of rash, bilateral upper and lower extremity swelling, shortness of breath, and she also noted to have a headache. So for some background, she actually came straight from the PDX airport to our hospital because she'd been in Mexico for a week, and her stay there was notable for being treated a couple of times for heat exhaustion symptoms with some IV fluids and some IV ketorolac, and around that time is when she developed that constellation of symptoms. And prior to the trip, she actually noticed a swollen lymph node on the back of her nape. And she has no personal or family medical history and takes no medications up to this point, at least. So in the emergency department, she was noted to be afebrile with tachycardia and tachypnea, normal blood pressure and SATs. Her initial exam was notable for being uncomfortable, not looking too well, breathing heavily, but having clear lungs and having sort of diffuse bilateral lymphadenopathy, as well as a confluent maculopapular rash of the lower extremities and upper, as well as a lower, actually non-pitting edema. So initial labs, I've thrown some up there and highlighted some of them. I think they're notable mostly for this significant leukocytosis, very high LDH, very high CRP. And as you can see, she got an elevated D-dimer, recent travel, so I'm sure it's a mystery what happened next for her. So she had a CT pulmonary angiogram, did not show any pulmonary embolism, but you can see I've highlighted there was actually diffuse mediastinal and hilar lymphadenopathy. Ends up getting an abdominal CT scan as well, shows some splenomegaly and some diffuse lymphadenopathy, but no other acute abnormalities were noted there. So I thought this would be a good opportunity. I know I'm late to the party a little bit, but in thinking retrospectively about this case, dipping my toes in the artificial intelligence realm, so I consulted our friendly chat GPT there. It's the first time I've ever done that. It was very nice. And I thought it was also good that they made sure to highlight that we are not obsolete yet. They have not yet taken our jobs, so felt reassured about that. But it does give a nice list here that I've kind of adapted into this diagram, and we're going to kind of fill that out as we go forward. The other thing we're going to be filling out is my internist high value care board to keep track of our consults that we accumulate throughout our hospital stay here. So we'll be checking those off. So early on in her hospital course, she became febrile actually on the first night. So she started on broad spectrum antibiotics, had cultures obtained before that. For her swelling and shortness of breath, she had an echo done, but it didn't show any abnormalities. So she's treated empirically crucially for symptom control with some diuretics. Oncology was the first one consulted. Of course, they wanted some tissue with all this lymphadenopathy, so we got general surgery on board, and they went ahead and got right to that and did an inguinal node biopsy the next day. So you kind of see, we're sort of covering for and working. I'm thinking about infection. We're really thinking about malignancy, and maybe from history, we can sort of start crossing off some of the other differentials here. So moving forward, this was also noted. Red blotches on her eyes. And we're like, oh man, what is that? Talk to optho, and optho says, well, actually, it's probably just from sneezing. It's not some crazy lymphoma or something like that. So we're like, okay, that's interesting. So this is sort of where we are right now. We're making some good headway with our consults thus far. And so preliminary workup, the initial pathology was so convincing for a potential malignancy with atypical cells that Onc said, before this finalizes, just go ahead and get the PET scan. And that was read verbatim in the report as compatible with lymphoma. You can see some increased splenic uptake there. And right, so what is it, cancer? What cancer is it? Of course, it's not cancer. I wouldn't be talking about a nice windy course if it was. So flow cytometry ends up coming back after about 2 weeks, and so did the gene rearrangement studies. They're both not consistent with malignancy. So oncology says, okay, it's not us, get a skin biopsy. Is it some sort of autoimmune vasculitis or something like that? So now we've gone from green to red on our malignancy. We're still covering for infection, or are we? Well, actually, no, all the cultures return negative. There's no source on imaging. She got 8 days of empiric IV antibiotics and actually has been off of them for almost a week at this point before we stopped the cancer workup. But she's still swollen. She's getting escalating doses of diuretics. Her albumin's dropped, maybe acute phase inflammation. So she's on pretty hefty doses for a naive person to diuretics. And unfortunately, her blood pressures end up getting soft, maybe because of the diuretic, and she gets some albumin because she's also hypoalbuminemic, which you think, oh, that might work, but it actually didn't work. Maybe did the opposite. She developed an acute reaction to that, maybe some component of anaphylaxis, maybe some component of sepsis, and she develops shock. So her blood pressure actually gets a lot worse, and she has to go to the ICU for vasopressors, steroids. Same time, her hemoglobin dropped by quite a bit in 1 day. So we got all this stuff going on, and then I see her for the first time in the intensive care unit. So we stabilize her there. We get her on some stress dose steroids. We get her on some antibiotics. No signs of bleeding anywhere, but we give her some red blood cells just to plump up her hemoglobin back to the appropriate levels. ID actually felt that, look, the only thing you haven't covered for is toxic shock syndrome with the constellation of her symptoms. So we actually called up to the OB-GYN floor and got a speculum to do an exam in the ICU. And that was actually completely normal. There was no retained products or any signs of anything untoward there. So sort of here now, right? ID said it's not infection. So, and now here's some pictures of her skin. You can see some of the peeling and the edema, some of the redness actually looks better at this point than initially. And then those are the legs. So derm comes by, does a skin biopsy. And it's read as, again, it's not definitive. Nothing in this case is. Maybe DRESS syndrome from the ketorolac, maybe phototoxic dermatitis, maybe toxic shock, which we've kind of ruled out, maybe SLE. So we're like, okay, like call rheumatology. We're like, no problem. We're calling everybody. We'll call rheumatology. So we send a broad autoimmune workup. And she does get better pretty quickly within about 3 days. We're able to get her on oral steroids, off pressors, and she's still on antibiotics for septic shock. We don't have a source. But she did get out of the ICU after hospital day 18 at this point. So now we're sort of thinking, okay, maybe it was a drug reaction, maybe it's autoimmune. It's probably not those other things. No granulomas on any tissue that we got. So it's a little bit difficult here, but we did nail the bingo here. We got 7 different consults called at this point, so we're rocking out there. So she comes back to the floor, and we end up sending her home on a steroid taper, basically. She does an empiric course of IV antibiotics. This persistent anemia, oncology said work up for hemolysis. It was negative. Her blood count stabilized. She ends up with a few units of blood. Not entirely sure what's going on there. And her edema improved in tandem with the steroids, as did her skin findings. So she didn't go home with any diuretics. And I've been following the case sort of afterwards. So of all the tests that were sent, her dsDNA was positive, her ANA was negative, EBV and Parvo were positive, and rheumatology wants to wean her off the steroids and repeat the lab tests, but she got weaned off, and then her symptoms came back and then she's back on steroids, attempting to taper again, and that's sort of where we are, almost up to date right now. So what is the final diagnosis, right? Is it stress? Is it some weird lymphoma we haven't covered? Is it SLE or something else? And the reality is it that? Probably not, right? That can be the diagnosis in many different cases. But the reality is there is no definitive final diagnosis. Now, I'm sure many of my esteemed colleagues here, maybe that never happens to you, but I've found in a few years of training, it's happening quite frequently. So I wanted to think about how do I sort of square that circle? How do I approach that? So there's a few things I wanted to look at this case. So for the workup, we took kind of an in-series approach. Right, so we started on lymphoma. You could maybe say that's anchoring. It's been 14 days working that up. Well, we're sort of treating infection. That's kind of a can't miss. But the derm and rheum involvement wasn't until hospital day 15, and that involved a skin biopsy and some labs. That could have been sent at any time. In fact, you could say that most of this workup could have been done outpatient entirely. What kept her in the hospital was her initial course of IV antibiotics and IV diuretics, the latter of which was probably not a good idea. It was purely for symptom control, not for heart failure or anything like that. So that was my key question there. And there's the financial implications. We have some numbers sort of for our ICU, $10,000 for a 2-day ICU stay, and for the procedure as well. The whole hospital stay is probably easily $25,000 because it was 21 days. So there's a big burden on the system there as well. And then safety implications, we know from many studies and intuitively that longer hospital stays are associated with more morbidity and mortality, higher rehospitalization rate. And my concern is that the ICU trip with the diuresis and the albumin was iatrogenic, and that maybe getting her out of the hospital around day 10 or so might have prevented her from getting sicker and being exposed to negative outcomes there as well. So tough case, but, and then the other thing for me was sort of reflecting on the uncertainty around things. I think for us as internal medicine doctors, we want to get the diagnosis. We have the ownership of the patient and we want to figure out what's going on and try to fix it if possible. But ultimately, we're not necessarily able to do that all the time. And I think as we get along in training, there's a concept called uncertainty tolerance that I was reading about, and that's something that we have to try to develop. So, and that rolls into my takeaways. So being comfortable with that uncertainty is crucial. And I think that we can't expect to diagnose or solve all the problems when we have the patient in the hospital. So it's crucial to rely on the outpatient setting as well, because we're all part of the same system taking care of the patient ultimately. So we have to develop that kind of comfort. And the other thing is for these sort of complex undifferentiated problems that patients come in with, we should consider sometimes early parallel workup if we know we're going to have them for a while. So yeah, I think, you got to come to terms with things being unsatisfying, and, hopefully this talk will at least get you started there. So yeah, thank you very much for listening.
Great. Many thanks, Dr. Pandher. We have just a few minutes left. Any thoughts on the case or any questions from our audience?
Thank you, Dr. Pandher. You threw us the Cabo bone early, and I was curious what the team's thoughts were about any weird exposures. Did you get a jellyfish or a scorpion or something that triggered this?
Yeah, we did go through that with our wonderful ID specialist. Even shellfish were some things he was thinking about, but she hadn't really gone swimming or had any untoward things. She was just more sunbathing on the beach. She's been to Cabo before. She didn't really do anything that she hadn't done before. Again, dermatology was thinking about the ketorolac that she got maybe causing dress, but apparently she got that in the past as well and hadn't had issues. So it just, there was no obvious exposures or anything done while she was away that was leading us to anything, unfortunately. So
I'm amongst the 50% of physicians who have barely heard about alpha-gal syndrome. Is she a meat eater, and was there any correlation with eating meat? So alpha-gal is the Lone Star tick disease. It results in an allergic reaction to meat products.
Yeah. She was a meat eater, and she had no changes to her diet. We actually also talked about tick-borne diseases with the infectious disease. They said the rash didn't seem to be like that for the classic diseases. That didn't seem to be necessarily the case there. So
Great. While others have a chance to ponder their thoughts in the room, I'll ask one other Dr. Pand here. So I actually find tolerance of uncertainty an important and fascinating topic. I think one of the challenges within it as a general internist and particularly early training or early career is to know when is it that I just don't know the answer and when is it that the answer cannot be known. Any comments as you interacted with specialists or reflected on this case for tools of parsing out sort of individual versus universal unknowns?
That's a very simple question like that. So I think
5 minutes left. So.
Yeah. Well, I think that, I mean, it's tough because I think there's always the possibility that there's something rare that you or the specialist can't pick up on. But I think the way that I like to think of things is, it's good to be able to sit down and talk with people like with ID, like they literally sat down, we went through everything that we could, but you can't always do that. Sometimes, people are pressed for time and whatnot. I think that we have a system that's not perfect, which means that things are going to get missed, and we have to do our best. So I think we sort of have to trust what it is as it is set up. And what I mean by that is that you involve these specialists, you have the discussion, you communicate as much of the information as possible. You reach back out to them if you have something else that comes up or if you want to make sure. So you do your due diligence, but ultimately the chips are going to kind of fall as they may, as long as you, I think, make the right calls, you go through the right workup. And if you're still stumped, then I think if you've exhausted the possibilities of what's available to you in terms of expertise and imaging and pathology and whatever, then there's just not much more you can do. And I think being willing to ask for help earlier is probably a good idea, especially if someone comes in with these sort of general complex complaints or just undifferentiated, and you're just like, okay, I've done my basic stuff but I don't know what's going on and I'm worried they could get sick, then we should find the appropriate person and start working on things.
Great. Thanks for your thoughts to a very complex question. Yeah. And I love that you're continuing to follow along. I often find passage of time and curiosity important ongoing tools, and perhaps just a willingness to continue to walk the path with the patient because many cases remain uncertain over time.
Yeah.
Well, wonderful. We'll give a final round of applause for all of our outstanding residents. Thank you.